Good day, dear students. So today's lecture is about irritable bowel syndrome, or so-called spastic colon. So what is it? It's a functional disorder which is characterized by recurrent abdominal discomfort or pain that is accompanied by at least two of the following symptoms: relief by defecation, change in frequency of stool, or change in consistency of stool. The prevalence of IBS in general population varies between 5 till 20%. Irritable bowel syndrome is common, affects females, but sometimes we may see it in different ages. More common, it's begin in adolescence or near 20s. But sometimes onset of this disease can be in adults, more rare in elder patients. So the cause of irritable bowel syndrome is still unknown. So no anatomic causes can be found in different laboratory tests, in X-rays or in biopsies. Some emotional factors, diet, some drugs or hormones can precipitate or aggravate gastrointestinal symptoms. Also, we know that irritable bowel syndrome is a combination of psychosocial and physiological factors. So, what psychosocial factors may take role in etiology of this disease? Some anxiety disorders, depression, somatization disorder, sleep disturbance, stress and emotional conflict. Also, abdominal pain processing in the central nervous system, and we said that pain is a very often symptom of IBS. Also as etiological factor, some dysregulation of intestinal immunity can take place, low-grade inflammation and altered gastrointestinal permeability following enteric infection, and some intestinal imbalance of intestinal flora, so dysbiosis so-called. What physiological factors also take place in etiology of irritable bowel syndrome? We may divide them in some main, so visceral hyperalgesia, dysfunction of autonomic nervous system, different changes of motility, lower colonic transit in constipation, and in diarrhea, faster colonic transit. As aggregated gastrocolonic reflux, and some hormonal fluctuation in women organism. What are the main symptoms and signs of irritable bowel syndrome? Symptoms rarely lose their sleeping of patients. Symptoms are often triggered by food, more often by fats, or sometimes by stress. What do we know about abdominal discomfort in irritable bowel syndrome? So it varies considerably and associated with alterations in stool frequency. We see increase in diarrhea predominant IBS and decrease of it in constipation predominant IBS. Consistency of stool also will be changed. It can be loose or lumpy and hard. Located abdominal discomfort more often is localized in the lower abdomen, striddy or cramping in its nature, and relief by defecation. Other symptoms and signs of irritable bowel syndrome are feeling of abdominal stool passage, straining, urgency, or feeling of incomplete evacuation. Patient can have such complaints. Pes mucus, bloating, abdominal distension, dyspepsia, intraintestinal symptoms like extraintestinal symptoms like fatigue, fibromyalgia, different sleep disturbances, chronic headaches. So quite unspecific symptoms also can be present in patients with irritable bowel syndrome. How can we put this diagnosis? So we should use some criteria which are recommended now for determining of this diagnosis. So it's clinical evaluation, which is based by Rome criteria, so-called Rome criteria, screening for different organic causes with main basic laboratory test and endoscopy, sometimes X-ray. Other tests for the patients with so-called red flags. So we should, if we see these symptoms, these markers of possible disaster in abdomen, we should examine the patients more properly. So what are they, these red flags? It's if we see pain or discomfort in abdomen which is connected with defecation in elder patients, which have fever, weight loss, of course rectal bleeding if they have, and vomiting. So in these patients we should make some more examination, some more tests to exclude malignancy. With what diseases we should differentiate irritable bowel syndrome? First of all, with lactose intolerance, with drug-induced diarrhea, post-cholecystectomic syndrome also, laxative abuse, some parasitic diseases, also with eosinophilic gastritis or enteritis, which more common take place in food allergy, microscopic colitis, small bowel bacterial overgrowth, celiac disease, early inflammatory bowel disease, and ischemic colitis. Sometimes also we should differentiate IBS with disorders of calcemia in organism, which can take place in hypo or hyperparathyroidism or hypothyroidism, in chronic pancreatitis, in tropical sprue, in Whipple disease, in celiac disease, hypothyroidism, in gastenoid syndrome, and in Gastronoma. So in all these diseases we may see this similar clinical picture, and we should differentiate IBS with this organic pathology. So few words about carbohydrate intolerance. It's quite spread in human population. It's caused by disaccharide deficiency, usually of lactase. Sometimes can be acquired or congenital. Because of disturbed digestion of disaccharides, there are some changes of osmotic load in intestine, and it causes diarrhea. Also, intestinal bacteria metabolize some undigested disaccharides, and it's lead to increased production of gases, and as a result, meteorism and flatulence. For determining of this pathology, we should use some clinical tests. A hydrogen breath test, it's a gold standard for this GIT disturbance. And the main for control symptoms of this disease is dietary restriction, it's more often it's enough to make patient's condition better. This is information for you. What does it mean, hydrogen breath test? So how we will perform it, and lactose tolerance test, which is less sensitive but also can be used for determining of carbohydrate intolerance. In some patients, we may find Adenophilic gastritis. What is it? It's intensive infiltration of mucosa, submucosa, and sometimes muscle layers with eosinophils, and it more often affects an enterium of the stomach. Eosinophilic gastritis or enteritis quite frequently has connection with food allergy, and the main symptoms of it, it's nausea, vomiting, early satiety, and to put this diagnosis we should perform endoscopy with biopsy and determine this infiltration by eosinophils of mucosa and other layers of the stomach. Another disease which has also similar to IBS clinical manifestation is Gastronoma, but this disease, of course, is more aggressive and more dangerous for the patient. So what is Gastronoma? What do we know about it? Most Gastronomas manifest with peptic ulcer symptoms, but sometimes the first symptom can be diarrhea. About half of the patients with multiple Gastronomas and about half of them have multiple endocrine neoplasia syndrome, and half of Gastronomas are malignant. So if you see clinical signs of Gastronoma, you must try to find the tumor, because you should remember that in half cases it can be malignant. To put this diagnosis, we should use some laboratory tests also. We detect serum gastrin level, and sometimes we need to perform secretin provocative tests. Tumors we can visualize using CT, sometimes somatostatin receptors scintigraphy, or by PET. Acid segregation is suppressed with proton pump inhibitors, the most effective anti-secretory drugs. In some cases, if it's not enough, we may use octreotide, or of course, if we was so lucky and find the focus of tumor, the tumor mass, surgical removal of it, it's the best treatment, and of course making biopsy to understand if this tumor mass is malignant. What is bacterial overgrowth syndrome? Also, it's quite often pathology, but it's quite poor investigated in our population, but we should remember about it. So what is it? Some anatomical changes in stomach and intestine lead to gastrointestinal stasis, and due to it, passage through the GIT is disturbed, and thus bacterial overgrowth takes place. These bacteria deconjugated bile salts and disturbed fat metabolism. The most often symptoms of bacterial overgrowth syndrome is abdominal discomfort, diarrhea, bloating, excess flatulence, and steatorrhea. So quite near to exocrine insufficiency in chronic pancreatitis, for example. How we may put this diagnosis and differentiate it from other diseases with the same clinical picture. So we may perform culture of intestinal fluid, taking aspirate, and see what is the bacterial count of it. And another non-invasive test, which is also quite informative, it's xylose breath test, which we may use for detection and differentiate bacterial overgrowth syndrome with other diseases. No, of course, the treatment of this syndrome is oral antibiotics. And some recommendations about diet, so high fat and low carbohydrate diet, which also may decrease symptoms in patients with bacterial overgrowth syndrome. Another disease about which we should remember when we see patients with possible irritable bowel syndrome, it's celiac disease. So what is it? Celiac disease involves an inflammatory response to gluten, and in a time it leads to bilious atrophy and malabsorption syndrome. More often, people of Northern European heritage are affected by this disease. In adults, we may see lassitude, weakness, anorexia, which are the most common symptoms. If manifestations take place in children, so there are some other clear complaints and clear symptoms which help you to differentiate celiac disease from other diseases which manifestate with the same clinical picture. So mild or intermittent diarrhea sometimes take place. We see also mild or severe steatorrhea in celiac disease. Some patients have loss of weight if it's children or adolescents, so they have decreased growth because of malabsorption. And also quite specific for celiac disease abnormality is dermatitis herpetiformis, which we may see in about 10% of patients with celiac disease. Also, for celiac disease, anemia, glossitis, angular stomatitis, and aphthous ulcers are usually. We may see in a time vitamin D deficiency and calcium deficiency, which manifestate with osteomalacia, osteopenia, osteoporosis, sometimes with fractures. So as in men and in female can be some problems with fertility. In women may be amenorrhea also. To detect special markers of celiac disease, we should make some serological tests in which we may find positive anti-tissue transglutaminase antibodies and anti-endomysial antibodies. And to prove celiac disease, also we should perform in all cases small bowel biopsy. And in biopsy material we'll see atrophy of mucosa. The main for the patient with celiac disease is a following of gluten-free diet. And if patient has malabsorption, so we should replace vitamins and minerals which are in deficiency. Another disease with which we should differentiate irritable bowel syndrome, it's Whipple disease. So what is it? It's quite rare disease, but also we should remember about it because it has some specific clinical manifestation and quite specific treatment. So it's caused by bacteria, affects different organs, also gastrointestinal tract. Small bowel mucosal involvement causes malabsorption syndrome. We may think about or suspect Whipple disease in middle-aged white men who have also arthritis besides abdominal pain, with diarrhea, weight loss, and, as I said before, some signs of malabsorption. To detect this disease, we should also perform endoscopy of small intestine, better with biopsy, of course. And in biopsy material, we should detect Tropinema whipplei, which is the main etiological agent of this disease. And because it's infectious disease, we should treat it by antibiotics. And antibiotic therapy is quite prolonged, sometimes till 1 year. And also, what is bad in this disease, that there are sometimes after so long antibacterial treatment, relapses also can take place in a time. So let's continue with IBS. So IBS, it's, as I said before, it's functional disorder, functional disease maybe, and we may put it when we exclude other morphological or organical diseases about which we spoke before. So how we may put irritable bowel syndrome? As I said, there are some so-called Rome criteria. Now we use Rome 4 criteria. So if there is a presence of recurrent abdominal pain or discomfort for at least 1 day per week during the previous 3 months, that is associated with 2 or more of the following symptoms related to defecation, associated with change of stool frequency, and associated with changes in stool form and appearance. So these are criteria using which we may put this diagnosis, irritable bowel syndrome. So one more time, it's presence of recurrent abdominal pain or discomfort, so can be as pain as discomfort for at least 1 day per week during previous 3 months, and it must be associated, this pain and or discomfort must be associated with 2 or more of these following symptoms. It's relation with defecation, it must be associated with stool frequency or stool form or appearance. The diagnosis of IBS can reasonably be made using the Rome criteria as long as patients have no red flag findings. I said before, what are these red flags? It's age, patients which have vomiting, weight loss, blood diarrhea, anemic syndrome. So as I said, it's signs of possible malignancy. Of course, if patient has one of these red flag findings, first of all, you must exclude gastrointestinal cancer. Sometimes physical examination can help us to differentiate IBS from other diseases. In general, more often patients generally appear to be healthy. Palpation of abdomen may reveal tenderness, particularly in left lower quadrant. Sometimes can be tender sigmoid. In digital rectal examination, including a test for occult blood, no blood must be found. But in all patients, we should make this examination. In women, pelvic examination helps to differentiate ovarian tumors and cysts or endometriosis from irritable bowel syndrome. Some laboratory tests also can be useful, of course, for better differentiation from other diseases. So we perform common blood tests, some biochemical markers, including liver tests, liver function tests. ESR sometimes also will be helpful to understand if patient has inflammation in organism, for example, or malignancy. Stool examination for ova or parasites. As we said, sometimes GIT problems has patient with disorders of thyroid glands or parathyroid glands, so we should check the level of thyroid stimulating hormone or calcium level in patient with constipation. To differentiate also from other diseases, we may use some X-ray tests. Also quite informative can be fecal calprotectin level. And for better differentiation with biopsy, we may use endoscopy, rectosigmoidoscopy and colonoscopy if it's necessary. So endoscopy maybe will be the most informative, not maybe, it's the most informative method for all GIT problems, as upper part of GIT as lower part. So because of possibility of biopsy tests, endoscopy will be sometimes the most informative test which we'll perform to differentiate IBS from other agenical problems. In some cases, we should use some additional tests like CT scan or ultrasonography, sometimes X-ray with barium, gastroesophagoduodenoscopy if we think about possible problems with problems in upper part of GIT. For detection of small intestine problems, we may use video capsule endoscopy, small bowel X-ray also, and fecal fat excretion for detection of malabsorption. Changes in symptoms or new symptoms or complaints may be a marker of a new disease. So if before you put a diagnosis of irritable bowel syndrome, if patient has some changes of previous symptoms or appearance of new symptoms, you should remember that it can be a debut or manifestation of the new disease. So you start investigation, complete full investigation, not to miss any other problems which can be with similar clinical picture as irritable bowel syndrome. So we should properly monitoring all symptoms which was before or new symptoms, location, type or intensity of pain, bowel habits, constipation or diarrhea, appearance of nocturnal diarrhea also, to put correct diagnosis in time and not to miss first of all malignancy. So how we may help the patient with irritable bowel syndrome? What's about the treatment? So as we said before, irritable bowel syndrome, it's a combination of psychosocial and physiological disorders. That's why we should explain the patient that his disease is not dangerous, but symptoms may be quite unpleasant. So maximum support and understanding of patient's problems. We should explain the patient about diet, which also can help him to decrease symptoms and unpleasant complaints. We recommend avoid gas-producing and diarrhea-producing foods if patient has increased flatulence and diarrhea. We recommend increased fibers if patient has constipation. And of course, some drugs also can be helpful for some symptoms to control symptoms of IBS. So we should explain the patient about the etiology and pathogenetic mechanisms of this disease. We should explain him and maybe try to find in anamnesis any connection with stress or any kind of food. We should explain the patient that he has no serious or life-threatening disease. So patient must understand that his condition is benign. Physiological stress, anxiety, or mood disorders should be identified, evaluated, and treated, because we said psychosocial problems very often push the first manifestation or make the flow of this disease more aggressive. Regular physiological activities help also to relieve stress and improve bowel function. And regular physical exertion activity we should recommend for the patient with constipation. What about diet? So diet is quite important field in the treatment of IBS. So we should explain the patient what diet should he maintain. So meals should be not over large, and eating must be slow and with small portions and quite frequent food intake maybe. We should recommend to increase flatulence to decrease some products which stimulate increased gas production. So eliminate beans, cabbage, or other foods which has increased amount of carbohydrates. Also, we should recommend to reduce intake of sweeteners like sorbitol, mannitol, fructose, and some other foods like apple or grape juice, bananas, nuts, and raisins, which also may provoke flatulence, bloating, and diarrhea. Some patients with IBS also can have lactose intolerance. That's why, of course, we should recommend to exclude or reduce intake of milk products and dairy products. For some patients, we should recommend low-fat diet to reduce postprandial abdominal symptoms. For patients with constipation, we should recommend fiber supplements and increase amount of fluid intake. So you see what we should recommend to increase contain of colon. For patient with constipation, also we should recommend regular physical exertion activity, but the same we should recommend not to do with for the patient with diarrhea. So less fibers in diet for them and less activity sometimes we should recommend. But also these recommendations are very individual, because in the same patient can be periods of diarrhea and periods of constipation. For some patients, trying to normalize gastrointestinal motility, we may use anticholinergic drugs like histamine, for example. It has quite good antispasmodic effects and prevent or relieve pain, and also sometimes normalize motility of gastrointestinal tract. In patients with constipation predominant IBS, we sometimes should recommend chloride channel activator lubiprostone in the dosage you see in this table. And for diarrhea predominant IBS patients, we may use oral difenoxylate or loperamide sometimes to stop diarrhea if diarrhea is quite aggressive and intensive. But we should remember that prolonged intake of loperamide we should avoid, because in a time there can be constipation, and patient's condition also will be not pleasant due to it. In some patients, to normalize flora of intestine, we should use antibacterial drugs, for example rifaximin. It has a specific antibacterial action only in intestine, with less side effects and with absence of general action, antibacterial action. So for the patient with IBS with diarrhea, we sometimes should recommend rifaximin for the course of treatment to normalize, to depress pathological flora if it takes place. In some patients, we should use some drugs which interact with serotonin receptors. So allocetrone, such drug from this group, it can be helpful for the women with irritable bowel syndrome with diarrhea, which are refractory to other drugs. But for aged patients, this drug is not recommended because it can provoke ischemic colitis. In patients with also severe diarrhea due to IBS, in some patients we may use a drug with mixed opioid receptor activity, eluxadaline, but it's quite specific and individual treatment. As we said before, different psychic problems may provoke manifestation or exacerbation of irritable bowel syndrome, and also to control pain syndrome we may use tricyclic antidepressant and secondary tricyclic antidepressants, which you see below. And we may try to use them because some of them has analgesic effect and anticholinergic and sedating effect. So this group of drugs may be quite effective for the patient with IBS with different flow of it. You see the dosage and drugs which are most effective in patients with irritable bowel syndrome to interact with the central nervous system and peripheral sometimes nervous system. As also we discussed before, irritable bowel syndrome can be associated with disbalance of normal flora or dysbiosis. That's why we may use and recommend probiotics to maintain normal flora of intestine. Sometimes because of psychosocial problems, so we may recommend cognitive behavioral therapy, which also may be effective in the treatment of patients with irritable bowel syndrome, psychotherapy, hypnotherapy, and of course trying to reduce stress, which quite aggressive and strong push mechanism of irritable bowel syndrome symptoms. So some relaxation techniques, psychical activities, regular exercises, physical activity. And so thank you for attention. I think that this information will be helpful for you for further study of gastrointestinal diseases and for detection of IBS and differentiation of it with other more serious and dangerous pathology which affects gastrointestinal tract. Thank you very much. Bye.